So moving on to the soft tissue injuries associated with the pelvis, hip and thigh region. We can break these injuries down into the various tissue types. So the common muscle injuries or common injuries to muscles and associated tissues include muscle tears themselves or irritation, inflammation of some of the bursae associated with the muscles, and certain syndromes associated with the region of the hip. In terms of muscle injuries, the common sites of injury that we see are injuries to the adductors, so the typical groin strain. We can see, although it's not common, iliopsoas strain, and fairly commonly we see tears and injuries of the hamstrings or the quadriceps. They are relatively common, and they're very much in the realm of the rehabilitation specialist from a treatment perspective. So the adductor strain, what do we mean by an adductor strain? This is usually a tear or an inflammation of the junction between the muscle and the tendon itself. And it's most commonly seen in individuals who are involved with sports that involve sudden acceleration or deceleration or sudden changes in direction. So typically footballers, hockey players, rugby players will present with these sorts of injuries. The pain is often fairly localized, and the individual may often describe symptoms at the time of the injury, so much so that it may actually stop them from continuing to play. So they have to abstain from playing anymore. On examination, on your clinical examination, invariably there is an identifiable tender spot. The commonest site of injury is the tendon of or the muscular tendinous junction of adductor longus in particular, although it's not the only one of the adductors that can be irritated. But we also get pain when we do an isometric contraction of the adductor group itself. If the tear is big enough, we will see extensive bruising. There's often bruising all the way down the medial side of the thigh, as muscles and muscular tendinous junctions are fairly vascular areas. So as these areas tear, blood vessels are damaged and there's extensive bruising. And it's not uncommon for individuals to develop recurrent tears in this region, often as a result of inadequate rehabilitation afterwards, which in turn leads to shortening and tightening of the muscle group and predisposing the individual to further injury. The groin strain is a tendinopathy of the adductor group. Okay. This may be a tendinitis, an inflammation of the tendon, a tendinosis, a degeneration of the tendon, and most commonly found in the tendons of adductor longus, brevis or magnus. It's adductor longus being the commonest one to get injured, as this is a fairly large muscle converging into a fairly small tendon. Again, the mechanism of injury usually involves sudden change of direction or repetitive twisting and turning, and individuals with a tightness of this region, tightness of the adductors themselves, may actually have a predisposition to this type of injury. So you should check for underlying causes. Biomechanically, individuals may be technically inept, or they may actually have biomechanical abnormalities of their feet. So consider that as well. If untreated, the adductor tendinopathy or the groin strain may lead to a rupture because of degradation of the tendon itself, or indeed may lead to a stress fracture, which can be identified using a bone scan. The groin strain symptoms are invariably poorly localized, and the symptoms themselves are often better if the individual warms up and loosens off. There is identifiable tenderness on palpation, and the pain can be reproduced on resisting adduction, or passive flexion, abduction, external rotation of the hip joint. This is known as Faber's test. Adductor tendinopathies do respond quite well to conservative treatment, but the treatment must be complete. It must include stretching and myofascial release of the tissues. It must include strengthening of the adductors, starting with concentric activities, but progressing to eccentric activities, as this will further strengthen the tendon and improve control in these situations. Assessment of contributing factors must also be considered. So check stiffness of other joints, things like the sacroiliac joint, the stiffness of the hip joint, and indeed abnormal mechanics of the knee and foot. Okay, another pathology that often gets confused with adductor tendinopathy is the Gilmore's groin, or the sportsman's hernia. This is an injury of the conjoined tendon of the abdominals. The conjoined tendon is the blending of the aponeuroses of the external abdominal oblique, the internal abdominal oblique, and transversus abdominis. Together, they form a common aponeurosis, which at the bottom here gives us the inguinal ligament, which is a fold in the abdominal aponeurosis itself. On the deep surface there is an opening known as the deep inguinal ring. Over here we can see on the superficial surface there is the superficial inguinal ring, and under normal circumstances an inguinal hernia will involve herniation of the abdominal viscera through the deep inguinal ring, down the inguinal canal, and emerging out here in the superficial inguinal ring. But in the absence of a true hernia, a tear of the inguinal ring is classified as a sportsman's hernia or a Gilmore's groin. There's usually a non-specific onset. It's a gradual onset of discomfort, and it's very common in individuals that do lots of twisting and turning activities, such as footballers. Pain is usually unilateral groin pain, which is aggravated by activity that involves lots of twisting and turning, so much so that after the game they find that they have to abstain from activity for a few days whilst the actual injury itself calms down. Clinical examination is poorly defined. Palpation of the superficial inguinal ring may be tender, and there may be a positive cough impulse. So if you place your finger in the superficial inguinal ring and get the individual to cough, they often describe pain, and you feel an impulse in that region in itself. If it's a true Gilmore's groin, the majority of these often end up going for surgical repair, and this is a straightforward hernia repair, in which a Dacron or Gore-Tex patch is applied over the tear, and they're then sent for rehabilitation, aiming to return to full normal activity between 4 and 6 weeks. However, some surgeons are now doing an alternative type of surgical intervention, which actually involves splitting the superficial inguinal ring further. This has been pioneered over the last few years, and the early indications are that there are some fairly good results associated with this. Iliopsoas strain may occur in the iliopsoas muscle. The iliopsoas muscle involves psoas major there and iliacus, and as they come together they form a common tendon that passes over the anterior aspect of the hip and the anterior rim of the pelvis. It's an overuse injury, and it's often associated with sudden or repetitive forceful flexion. So runners may develop it, or individuals that repeatedly kick using one limb, very unilateral footballers. Tightness of iliopsoas predisposes the individual to it, and this can be tested fairly simply using the Thomas test. Palpation is often difficult because iliopsoas is deep, but on some thinner individuals you may actually be able to get as far as identifying tender spots in the area. Pain, however, is often reproduced when you either stretch the iliopsoas muscle or produce a contraction of iliopsoas. Management is by relative rest, avoiding the activities that aggravate it, and stretching and strengthening the iliopsoas component. The strengthening must include concentric and eccentric control. Mobilization of the lumbar spine and or the sacral spine may help, as psoas major in particular attaches to the transverse processes and vertebral bodies of T12 to L5. Make sure that the hip maintains its rotation. Loss of internal and external rotation